So it's like, wait a sec, do we do all three, as in ACE, SGLT2 plus finerenone, or do we just do two of these? This is the Rounds Table. All right, welcome back, Rounds Table listeners. This episode is going to be another sort of crash course on guidelines, in particular, I should say, and no, I'm not going to edit that out. This will be the sort of top 10 takeaways from the recent Kidney Disease Improving Global Outcomes 2024, pronounced KDIGO, according to ChatGPT. John, welcome.
Hey, thanks, Mike. Yeah, I was wondering between that or is it kind of like bingo, like KDIGO? But we got a couple options.
Yeah, I'm going to trust ChatGPT, but any nephrologist, let us know if it's actually KDIGO or KDIGO, and bingo was his name-o. Okay, John, so we're not going to do all 200 pages of the guidelines because that's just completely indigestible, but I thought it was neat that you found the sort of top 10 takeaways. So did you want to start us off?
Yeah, why don't we take it away? So first up, the guidelines really emphasize the importance of a healthy and diverse diet. People with CKD should be encouraged to eat a diet that includes higher consumption of plant-based foods compared to animal-based foods and should have low consumption of ultra-processed foods. In particular, diets like DASH and Mediterranean should be encouraged. So why these recommendations? Well, it is thought that diets low in animal-based and ultra-processed foods may help slow the progression of CKD and ultimately delay the need for dialysis. Another component around diet centers on protein consumption, so the guidelines suggest maintaining a protein intake of 0.8 grams per kilo in adults with a GFR of less than 60. Sticking to a lower protein diet can be challenging though, and when trying to balance harms and benefits, one of the main considerations is really trying to avoid high protein intake, in particular less than 1.3 grams per kilogram per day in adults with CKD at risk of progression. And I guess the last point, which is one that we do think about, I think, is to remember to encourage patients to limit their salt intake, in particular less than 5 grams of sodium chloride per day or less than 2 grams of sodium per day. But really, with all that said, physicians' knowledge when it comes to dietary optimization is usually not all that great. And so practically speaking, if you have the resources, get a dietitian involved to help care for your patient.
Yeah, totally agree. And even as you said, like the importance of the DASH diet in real time. Case in point, I asked ChatGPT, remind me, what is the DASH diet? So for anyone else who doesn't remember, emphasizing fruits, vegetables, whole grains, limiting red and processed meats, limiting added sugars, limiting potassium intake. But I also feel like this is really ripe for a randomized trial. Like, how much of this advice is based on data versus just expert opinion? I don't know, but I'm not aware of any massive trial in the New England Journal of Medicine which actually compared diet A versus diet B. How about you, John?
I know, I am sure some nephrologists would be able to quote research, but I was a little vague when I said that we think it might help slow the progression of CKD because I don't actually know what the absolute risk reduction, let alone the relative risk reduction might be when it comes to the dietary implications, but clearly it's important.
Yeah, I'm going to go ahead and state that there's probably no good randomized trial in this space. And, recently we covered that really neat trial, which I think was like fluid intake among patients with heart failure. And that kind of changed my practice to realize that, we probably shouldn't be telling our patients to, strongly restrict their fluid intake. But I'll stick to the script kind of, and we'll go to the next point. So the next point here is related to blood pressure control. The number 3 point, individualized BP control. That's right, we did skip one of the points that we don't think is overly relevant to internists. So with this point, the overall statement is that we suggest adults with hypertension and chronic kidney disease be treated with a target systolic blood pressure of less than 120 millimeters of mercury, which was kind of surprising to me. I did, pull back the curtain a bit more. And when you read the actual details in the guidelines, they state verbatim, randomized trials have not demonstrated that intensive blood pressure lowering results in meaningful reductions in the risk of kidney failure. But the randomized trial evidence supporting important cardiovascular benefits should encourage such a strategy. So, this statement is a grade 2B statement, which kind of makes sense because there clearly aren't large randomized trials to support what they're saying. The closest thing we have is the SPRINT trial, and the SPRINT trial randomized patients to aggressive blood pressure targets, less than 120 systolic, and doing so was associated with a 25% relative risk reduction in MACE. But remember, SPRINT excluded patients with type 2 diabetes, and type 2 diabetes is one of the most common causes of chronic kidney disease.
Yeah, and what's interesting, and perhaps is going to be the next guideline episode, is I'm pretty sure CHEP is just about to release like a 2025 update. And in that guideline, I think they're kind of being across the board saying the target should be less than 130 over 80. So it's just interesting that there are going to be differing opinions depending on who you ask.
Yeah, and they did have a nice caveat statement, which was a big but less intensive target for those at high risk of falls, frailty, fracture, limited life expectancy, or patients with postural hypotension. I just came off service a couple days ago, and I feel like almost all of the patients that I was caring for on the general medical unit was at high risk of falls, had frailty, risk factors for fracture, and many of them had limited life expectancy. So that's a really important asterisk beside this statement of targeting, a blood pressure of less than 120 systolic.
Yeah, that's a really good thing to remember, that the patient in front of you really matters when you're making those kind of treatment decisions. I guess moving on to the next point, this would be number 4, and it's really around some of the specific treatments and medications recommended for patients with chronic kidney disease. And it's really to remember the importance of RAS inhibition and SGLT2 inhibitors for patients with CKD, as these classes of medications have been shown to delay the progression of CKD. So what's the really important highlight? Well, start an ACE or an ARB and titrate to the highest approved dose. For SGLT2 inhibitors, start them as well, in particular when patients have a GFR above 20 with an ACR of greater than 200 milligrams per gram, which is greater than 20 milligrams per millimole, or if they have CKD with heart failure or diabetes, irrespective of the albuminuria.
Yeah, of course I'm on board with this point here. And I feel like the simplicity is that almost everyone with chronic kidney disease nowadays should really be on an SGLT2 inhibitor.
Yeah, I agree.
The other point I should mention for the blood pressure point is they really stress the need for home blood pressure measurements. And I think this is a great reminder. The blood pressure in the office is probably not accurate. Heck, the blood pressure we do on rounds is probably not accurate when somebody's in hospital. But anyway, John, any other points you had about RAS plus SGLT2?
I don't think so, no. I think just that one is nice and simple.
Yeah, and as I was, glazing over the guidelines, there wasn't a ton of mention on, well, how about GLP-1s, right? Like, what about the FLOW trial, which was a game changer? And the reason why I think GLP-1s weren't a major focus in these guidelines is just the timing. The FLOW trial, by the time it came out, these guidelines were already halfway out the door. Anyway, speaking of RAS and SGLT2s, this next point, we're at point number 5 now, is just highlighting acute changes in eGFR and which you should pay close attention to and which you should not. So the summary point here is just remembering that you expect to see an initial drop in somebody's estimated GFR when you start them on an SGLT2 or RAS inhibitor. Anywhere, 10 to 20% some odd change can certainly be observed. Now, when the change in the GFR is more than 30% from baseline, that is when you should really be pushing pause and identifying, is there another cause? Because the GFR shouldn't drop that much soon after starting an ACE, ARB, or an SGLT2. So again, the magical cutoff is GFR drops by more than 30% from baseline. You should be searching for another cause, be that they're taking a bunch of NSAIDs, there's an infection, there's something else going on. Only loosely related to this point, but the guidelines also discuss the importance of, when is maybe a creatinine in general not going to be all that accurate for estimating GFR, and instead you should use cystatin C. Before I go down this small rabbit hole, John, in the past year, how many times have you ordered a cystatin C?
I could tell you very precisely, it's been 0.
Yes, ditto, 0 as well. So I won't go too far down this rabbit hole as a result, but the short version is that if you have a patient in front of you who is malnourished, if they have an amputation, if they're cachectic, or if they're very muscular, creatinine levels are influenced by muscle mass, and a cystatin C is not. So in that scenario, you probably want to push pause and maybe fact check and order a cystatin C to see if their elevated creatinine is truly related to chronic kidney disease, or maybe it's not. Maybe it's just that grandma is severely malnourished and cachectic. Another time when, cystatin C is probably going to be the right answer. There are certain medications that can affect your creatinine, trimethoprim being one of them. And I think, when in doubt, I would say ask a friendly large language model or a friendly nephrologist, but just remembering that in certain scenarios, creatinine is not going to be a good indicator of somebody's glomerular filtration rate.
Yeah, that's really good. It reminds me of creatinine clearance, which is another number that I don't pay attention to very often because you got to calculate it. It's so annoying.
Yeah, there you go. Okay, John, back to you for the next point.
Yeah, so the next recommendation is around cardiovascular disease and imaging, in particular arterial contrast exposure in patients with CKD. So contrast-induced AKI is a controversial topic, and the links are actually thought to be weak. In fact, it's to the point now where instead of saying contrast-induced, the term contrast-associated AKI is really being more popularized. The biggest risk factors for contrast-associated AKI include patients with CKD, in particular a GFR of less than 30, those who have diabetes, those with reduced intravascular volume for whatever reason, and those who are on concomitant nephrotoxic medications. There are also, though, procedure-associated risk factors, including higher osmolar contrast, large volume contrast, serial contrast exposures, and intra-arterial procedures. Unfortunately, CKD and cardiovascular disease go together, and so it's important to be aware of your patient's risk for cardiovascular disease, and the guidelines recommend estimating cardiovascular disease using validated risk tools, in particular the SCORE tool and the PREVENT equation. Otherwise, the recommendations really just focus on trying to use low and isoosmol contrast media, holding nephrotoxins 24 hours to 48 hours before procedures, in particular if the GFR is less than 30 or if they have an AKI. And I got to be honest, I don't know that I've always thought about doing that, holding their ACE or their ARB in advance of getting exposed to contrast. Metformin does come up a lot, but what they say is that metformin does not need to be stopped if the GFR is greater than 30, but if the GFR is less than 30, it's appropriate to stop it and not restart it for 48 hours. Regarding RAS inhibitors, withholding for greater than 48 hours to avoid potential for hypotension and hyperkalemia is kind of why they recommend that, and to then restart it if there's no AKI that develops or when the GFR returns to baseline.
Yeah, I am in the camp of very skeptical that contrast-induced nephropathy is even a real thing. I think the risk is so incredibly overstated, and if a patient truly needs their scan, a CTPE, the risk of contrast-induced nephropathy is so close to 0, even if they have an acute kidney injury. So yeah, that's one that really drives me kind of bonkers. In residency, we are taught that contrast can lead to AKI, and in medical school as well. But if you look at the data, the risk is so weak and so low. So yeah, I think it's, as more time has passed, I care a lot less about this because I think the risk is completely overstated. But without fail, when I was on service a few months ago, somebody had like a GFR of 29 and radiology just refused to do imaging with contrast for somebody's CT abdomen. And I had a call with the radiologist and I explained no, the patient's aware of the risk and aware that the risk is vanishingly low, and they just still wouldn't do it. And I asked, how come? And they said, it's a policy. And then I just died a little bit inside.
That is really frustrating. Yeah, because like you've already highlighted, what really comes down to is the patient in front of you. What do you think the diagnosis might be? What is the test that you need to kind of either confirm, rule in, or rule out that diagnosis? I still am going to pay attention to what my patient's GFR is. But, if you need the CT with contrast, if you need to work them up for coronary artery disease, what else can you do?
Yeah. Okay. Well, there you go. Next up, number 7. This might sound like a bit of a boring one, but I will try to make it exciting. Number 7, perform thorough medication review. And this is what we do on GIM. And this is why we love our pharmacists so much. And there's a few pearls, I think, that are kind of buried within this point. I think the first one we're pretty much aware of, using caution with NSAIDs. The other one, using caution or really just avoiding sulfonylureas in the setting of chronic kidney disease, keeping in mind that many of the medications we use for chronic disease are the so-called sick day medications, and many of them, not all of them, but many of them need to be held when somebody's severely, acutely unwell. And then there's a couple drug interactions that can pop their head up if you don't carefully review somebody's medications. So a really big one in the CKD population who's on an ACE or an ARB is Septra or trimethoprim sulfamethoxazole. That's really a drug you should be avoiding in lots of patients, even more so if they have chronic kidney disease and they're on an ACE or an ARB.
Yeah, and credit where credit is due. This was because of a really important paper that you published. I love talking about this with trainees as we're kind of running the list. There's a lot of good times when you need to consider Septra. Like, hey, what if someone's going to be on big dose immunosuppression? You're worried about PJP prophylaxis, but it's not a commonly known thing that there is that risk for hyperkalemia and sudden death. So it's always nice when you can kind of teach something new to somebody.
Yeah, I mean, and the real kudos goes to Dave Ehrlich on that one. I was just the resident on that. He was really the driving force. There's also a nice figure in the guidelines, and it's figure 26 for anyone who's following along at home. And it's just sort of a nice depiction of, you have a patient with hyperkalemia. What should you do with their ACE or ARB or finerenone, which we haven't talked about yet? I think for lots of patients with chronic kidney disease, if their potassium is less than 5.5 or so, of course, monitor them closely, but it's probably okay to continue their ACE or ARB or finerenone. And then when the potassium is above 5.5, acknowledging that is very arbitrary, but above that potassium, that's when you're probably going to be holding their finerenone, their ACE or ARB. Sometimes people ask if, do SGLT2s cause hyperkalemia? Absolutely not. They do not cause hyperkalemia. And if anything, there are a couple of recent studies to show that they might lower potassium, especially if somebody's on an ACE or an ARB. So that's really nice that maybe being on SGLT2 will mitigate the risk of hyperkalemia.
Yeah, I haven't seen that table specifically, but I think it was the cardiovascular guidelines from a couple of years ago that really gave you a nice clean table about like how to manage kind of the more mild to moderate hyperkalemia in the context of patients who would really benefit from these medications. And this is also a situation where I'll do my best to think about the patient's diet as well. Again, acknowledging that, eating an extra banana is not going to be the thing that makes or breaks your potassium, but there are a lot of other things within our diet that have extra potassium. And so I'll just kind of show my patients resources around low potassium diet to try to find other ways so that we can kind of, keep their potassium lower than, whatever it is, 5.5, lower than 6 for sure.
Yeah, and that reminds me of a couple points. So one, like what are the foods that are particularly high in potassium? This is something I always have to remind myself of, but the big ones are orange juice, avocados, bananas, as you've mentioned. Melon too is quite high in potassium. Sweet potatoes, also high in potassium. And it reminds me of a class of medications I don't often prescribe, the potassium binders. John, do you prescribe those at all or no?
No, not regularly.
Yeah, exactly. Me neither. And we won't go into detail in this episode, but I feel like in a future episode, we should cover the clinical trials for these newer potassium binding medications, because they certainly have a role in your patient who has bad chronic kidney disease and they really got to be on an ACE or an ARB, but they have ongoing hyperkalemia. It's a really nice opportunity to be using this class of medication, realizing though that it's hard to access and they are expensive. Okay, that is it for performing thorough medication review.
Yeah, nice. I kind of along those lines, point number 8, the last one that we'll cover today, is around when do you need to discontinue, but when do you also restart these medications? So if medications are discontinued during an acute illness, communicate a clear plan to the patient for when to restart them. So practically, what does that mean? Remind patients about sick day rules. In particular, stop their ACE, their ARBs, their diuretics, their SGLT2s when dealing with specifically say like an acute dehydrating illness is kind of the threshold, and ensure patients know when to restart these medications so as to minimize excessive time when they're on hold. But also documented in the medical record, in particular, in hospital, we often do a lot of stuff where we adjust doses or put medications on hold. So in the discharge summary, highlight to the receiving provider, be it their nephrologist, their family physician, okay, look, we're still keeping this ACE inhibitor on hold, but if you can recheck their creatinine in like a week's time and restart it if it's back to baseline, kind of clear plans so that everyone knows what's going on.
Yeah, I like that. And also the nuance of it depends why they're sick. Like if they're acutely sick from heart failure, you probably don't want to stop their SGLT2 and their ACE or ARB. But if they are acutely unwell from like gram-negative bacteremia, absolutely, those got to go on hold. And giving clear instructions to the patient so that they're aware is super important. So the last one, we're sneaking this one in. It's not on the top 10. But again, I wanted to sort of compare these guidelines to the prior KDIGO guidelines from, I think it's like almost 10 years ago or something like that. So in case people are wondering, all right, but like which of this is new? What's the new stuff compared to the prior guidelines? So one, SGLT2 being the cornerstone of CKD management, regardless of diabetes. I don't even think the last guidelines even mention the word SGLT2. Also, the use of finerenone. And we haven't spent a ton of time discussing finerenone today, but in the guidelines, they do make it clear that in patients with type 2 diabetes and CKD, they should be considered for finerenone. And that's based on two trials, the Fidelio DKD and Figaro DKD. I don't know why it doesn't end in CKD. Oh, probably because diabetic kidney disease. I bet that's what it was. Boy, I'm smart. So I won't do a deep dive, but Fidelio DKD, that was a double-blind randomized trial of 5,700 patients with CKD and type 2 diabetes, randomized to finerenone or placebo. They had to have an ACR of 30 to less than 300 and a GFR of 25 up to 60. The primary outcome was a sustained fall in GFR of 40% or death from renal causes. So, that composite outcome. The primary outcome occurred in 18% with finerenone compared to 21% with placebo, a 3% absolute risk reduction, which is actually pretty impressive. But a hyperkalemia was more common with finerenone. John, quick question. In the past year, how many times have you started somebody on finerenone for their chronic kidney disease?
Oh, yeah, guilty. That would also be a precise estimate at 0.
Yeah, no, I don't think it's not guilty. I think I'm in the same boat. And it's only been relatively recently that we could even get finerenone, and there is an LU code for it for patients with chronic kidney disease and diabetes. So that was the one trial. The second trial was called Figaro DKD, as mentioned, almost an identical design, but this study was looking at a composite of stroke, death from cardiovascular causes, MI, or heart failure hospitalization, and the primary outcome occurred in 12% with finerenone compared to 14% with placebo. So the take-home point is that in somebody who has chronic kidney disease from diabetes, finerenone improves renal outcomes and improves cardiovascular outcomes. I think the tricky part is that these trials were kind of occurring when the big SGLT2 trials were occurring for CKD. So it's like, wait a sec, do we do all three as in ACE, SGLT2 plus finerenone, or do we just do two of these? And I think that's an unanswered question, but please, any nephrologists who listen to our show, correct me if I'm wrong. The other new feature in these guidelines, as we mentioned, were cystatin C and when it should be considered. And again, the patient who has severely cachectic, maybe they have an amputation, severe low muscle mass, or the bodybuilder in front of you, in those scenarios, creatinine is not going to be accurate. And then they have some light sprinkling of the use of GLP-1s in these guidelines, which of course is new compared to the guidelines from a decade ago. But these guidelines don't discuss the FLOW trial because really it came out as these guidelines were coming out. Well, John, that was a lot of content, a lot of information. Anything else you wanted to say about these KDIGO guidelines?
No, I don't think so. I think we'll just have to keep tuned for whatever the next update is for KDIGO.
Yes, there you go. Good stuff on my end. Just a nice opportunity to share with the listeners about nephrology trial files. So nephrology trial files has been up and running for a year now, and it's a once monthly, maybe twice monthly newsletter that summarizes practice changing and throwback trials relevant to CKD using a large language model. Good stuff on your end?
On my end, Wes Anderson is back. The new film is called The Phoenician Scheme, and as a Wes Anderson fan, the trailer looks very Wes Anderson-y, and so I can't wait to see it.
Yeah, it sure does. I'm looking forward to it as well. All right, John, that is it for today. Take care, stay well, and talk to you next time.
Talk to you later, Mike. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.